Good afternoon, everyone, and welcome to today's webinar, COVID-19 Vaccine Distribution, Legal Issues and Challenges, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Strong, the Senior Digital Marketing Coordinator at the Network's National Office, and I'll be your host for today's webinar. We strongly encourage attendee participation and would love to hear from you, so feel free to submit questions at any time during this webinar by using the Q&A tab on the right-hand side of your screen. All you need to do is click on that tab, select all panelists from the drop-down menu, and send us your question. Your moderator for today's webinar is Leila Barraza. Leila is a senior consultant at the Network's Western Region office, as well as an assistant professor in community, environment, and policy at the Zuckerman College of Public Health at the University of Arizona. She'll be leading us through the rest of today's webinar, so Leila, over to you.
Thanks, Charles, and welcome everyone. Thank you all for joining us today. We have exciting presentations for you today, so I think we'll just jump right in to introduce our great panelists. First, we have Jennifer Piatt, who's a senior attorney with the Western Region for Public Health Law and a research scholar with ASU Center for Public Health Law and Policy. And we also have Doug Campos-Alcolt, a senior lecturer at the Melanie Zuckerman College of Public Health at the University of Arizona and a clinical professor with the College of Medicine Phoenix, University of Arizona. Today's webinar, we're going to focus on COVID-19 vaccine distribution, legal issues and challenges. And I just wanted to start us off with a few introductory notes before I pass it off to our two great panelists. While we are going to be focusing on vaccine distribution, I want to first acknowledge the hard work that went into getting us to this point to even discuss distribution of a vaccine less than a year from when this pandemic started. And we have here a quote from the FDA commissioner and others at the FDA showing the commitment to expediting the development of this vaccine, but doing so safely and making sure to not jeopardize the public's trust in our science-based independent review. So we know that development and manufacture of these vaccines was not without, overcoming many challenges, but now we have challenges that are current and emerging related to actually distributing this vaccine. And some of these challenges include allocation, authorization, both of which you will hear about today in depth in this webinar. There's also other current emerging issues involving liability, administration of the vaccine, challenges related to the 2-dose requirement, storage of the vaccine in cold temperatures can be, as we know, has been a challenge that local providers and states have had to address. And of course, vaccine hesitancy is a current and emerging challenge related to this and other vaccines. And we know that these are being addressed at a local and state and federal level currently. And to really dive into these issues further, I want to now pass it to Jen. Sorry about that. Pass it to Jen to lead us off with these legal implications related to the COVID-19 vaccine.
Thank you so much, Leila. Hi, everybody, and thank you all for joining us here today to discuss some important updates to the COVID-19 vaccine and the legal issues that accompany it. Now, as we all know, the COVID-19 pandemic has run rampant across the United States and the world, as indicated by the most current New York Times tracking numbers. As of yesterday morning, 68.3 million cases globally, 15.2 million in the United States alone, and upwards of 1.5 million deaths. The U.S., as of yesterday morning, again, had reached 286,443 deaths, making up almost 20% of the total deaths globally. As the pandemic continues to rage on, all eyes have turned hopefully towards a vaccine that could help to get this virus under control. Now, Doug is going to discuss the vaccine safety and efficacy process in a few minutes, but for now, the question remains. Once a vaccine is authorized, how is it allocated, and what legal issues result? So on the slide before you is an equitable allocation framework that was developed by the National Academy of Medicine. And if you look at phase 1A, it identifies high-risk healthcare workers and first responders, the high priority population, followed by people with conditions placing them at significantly higher risk, and older adults living in congregate or overcrowded settings. Now, the other phases follow afterwards, as you can see, but equity is a cross-cutting consideration across all of these phases. Additionally, the CDC's Advisory Committee on Immunization Practices, or ACIP, just recently on December 1st weighed in on the issue of allocation, and they issued an interim recommendation indicating that a vaccine that is both authorized by the FDA and recommended by ACIP should be offered in that first phase to healthcare personnel and to residents of long-term care facilities. The definitions of both of those groups are provided on the slides here, but with these potential initial allocations in mind or offered as guidance, some specific legal issues begin to arise. To that end, we've identified a top 10 list of core legal issues regarding COVID-19 vaccine allocation. Now, I want to note that these issues are identified in no particular order of importance. Rather, the organization of the issues here is one that I hope will take us through the story of vaccination to convey the process as it is starting to take place. First, the relevance of ongoing emergency declarations will heavily shape vaccine allocation. Public health emergency declarations at all levels of government trigger optional and expedited public health powers that can be used to respond to an emergency. The examples on this slide all come directly from Arizona statutes authorizing the governor to declare a state of emergency or a public health emergency. And taking a look at some of these, it's easy to see how the presence or absence of that ongoing emergency declaration can shape vaccine distribution and efficacy. For example, rationing medicine and vaccination, or isolation and quarantine powers. And indeed, we have already seen some governors lose some of those emergency declaration powers in court challenges, like Michigan Governor Gretchen Whitmer, for example. Now, emergency declarations are also going to be important with respect to who is actually able to administer those vaccines. Many states already allow for the reciprocity of healthcare workers during the pandemic or have taken steps to expand out scope of practice. For example, allowing pharmacists to administer vaccines in states where that's not normally allowed. And in order to really kind of drive home that these orders come from all levels of government, I wanted to discuss a brief example demonstrating that even with something like scope of practice limitations, which are generally the province of state administrative licensing boards, the federal government has actually gotten involved via its emergency powers. 28 states had already allowed pharmacists to vaccinate children, and an August order from the Department of Health and Human Services actually overrode other states' limitations on the practice, allowing it in all states. DHHS's justification here was that a continued routine vaccinations would be really critical heading into the school season. So suffice it to say that there are many reasons why these emergency declarations will continue to play that vital role in vaccine allocation. So it's going to be very important to look with fresh eyes at the state of declarations in any given jurisdiction once that allocation actually begins. Next, I'd like to turn to the legal challenges that may be presented against allocation schemes themselves. First, if states disagree with the potential allocation scheme proposed by the CDC, they will likely make challenges to that scheme or simply go ahead and implement their own on federalism grounds. federalism is essentially this. In the American system, there are two main levels of government, the federal government and state governments. Certain powers are held by the federal government, certain powers are reserved to the states, and certain powers are shared. And there are several examples of how that kind of distribution plays out in the Venn diagram on the slide before you. And as you can also see, providing for public safety is traditionally a power that's held by the states. So states will argue that they're exercising this reserved power in utilizing their preferred distribution scheme. On the other half of the slide, we also may see individual challenges being made to the scheme as certain groups are prioritized over others for that vaccine allocation. Individuals could potentially bring arguments based on the Equal Protection Clause, which protects against governmental discrimination, treating certain citizens differently than others or in an unequal manner. And whether these arguments will succeed is another matter, but it is likely that we may see some of these challenges being filed as soon as that allocation begins. Next, the FDA approval and EUA authorization process. This is key. The general FDA approval process is indicated on the slide in the blue arrow with key moments highlighted in the dark blue squares. And this is the process that a product is generally going to go through before it can be marketed in the United States. This approval process takes years. That said, two vaccine candidates for COVID-19 put forth by Pfizer with German partner BioNTech and Moderna have actually already applied for an expedited review process called emergency use authorization. Doug will cover this in much more detail later on, but basically through this process, the FDA provides access during an emergency to a product based on the best available evidence. We are smack dab in the middle of this process right now. The FDA's Vaccines and Related Biological Products Advisory Committee, or VRBPAC, is actually discussing the Pfizer-BioNTech EUA application today, and an approval or denial is expected shortly hereafter. And the Moderna vaccine will be discussed during an FDA hearing scheduled for December 17th. Without that authorization or another approval, full approval, the vaccines cannot be marketed in the United States. Now, another interesting piece of this puzzle is surprisingly political. We've seen politics involved in the FDA process on a large scale as the current administration put on the pressure for a vaccine before the election, even going so far as blocking new FDA guidance that would have derailed that timeline. Public confidence in the vaccine took a hit before FDA went ahead and published the guidance on its own, and the White House subsequently reversed course. Ensuring that public confidence in the vaccine is really going to be key to ensuring effectiveness because vaccines don't prevent disease. Vaccinations of people do. One pathway for restoring that confidence may lie with the CDC's ACIP panel recommendation. Approval from ACIP will be key as that guidance drives vaccination schedules followed by state health departments. Now, this is a great kind of point of transition into the next potential legal issue, which is that federal authority over state, tribal, and local governments. Distrust has been apparent not just from individual Americans throughout this process, but from state officials as well, arguing against CDC guidance regarding testing or wanting to actually vet those vaccines themselves. Now, federal approval does not necessarily lead to automatic state acceptance and distribution. And several states already, including California, Connecticut, New York, and West Virginia, have already determined that they'd perform their own evaluations of the effectiveness of the vaccine. And Nevada, Oregon, and Washington actually will be joining in on California's efforts there. So state distrust and differing state approaches could undercut a cohesive national immunization strategy, creating that patchwork of efforts that could potentially spend down the valuable resource of time. Additionally, states could face backlash from their own populations who seek access to an FDA-authorized and ACIP-recommended vaccine that the state itself has not yet accepted as safe. Our next emerging legal issue involves state vaccine mandates. Now, the ability to vaccinate actually falls squarely within state police powers. And we're not talking about powers that cops or police officers hold. Rather, what state police powers are is encompasses that inherent authority of the state to legislate and to regulate, to protect, preserve, and promote health, safety, morals, and the general welfare. In the vaccination realm, this power was acknowledged in two famous early 20th century Supreme Court cases. First, in Jacobson versus Massachusetts, the court upheld a mandatory smallpox vaccination scheme, the penalty of which was payment of a $5 fine. And later, in Zucht versus King, the Supreme Court acknowledged states' power to mandate vaccination of school-aged children. And I want to make one point of terminology distinction here before we continue on. Generally, when we're talking about mandates to vaccinate or a mandatory vaccine, we're talking about conditions that are being set on participation to encourage vaccination. For example, requiring school children to get vaccinated in order to obtain that privilege of attending school. Compulsory vaccination is somewhat different, requiring participation irrespective of consent. Now, normally, without consent, they're not jabbing needles into people's arms forcibly. Rather, quarantine or isolation measures might be used. An example of using these kind of isolation or quarantine in a situation of vaccine refusal can be found in New Mexico's Public Health Emergency Response Act. So while states often mandate school-aged children to get vaccines, many states actually have statutes allowing for compulsory vaccination during a declared emergency. And this is yet another reason why assessment of those ongoing declarations of emergency remains really important. A second important piece of this mandate puzzle is employer-mandated vaccination. Many employers and employees have wondered whether private employers could require employees to get a COVID-19 vaccine. And the answer generally is yes. Because the U.S. system is built largely on at-will employment, employment can generally be terminated for any good reason. This is, of course, subject to written employment contracts, state laws preventing termination for certain bad reasons, etc. For example, here, hospitals might require healthcare workers to get certain vaccinations in order to start working or continue working there. That said, there are some limitations on this power. The Equal Employment Opportunity Commission, or the EEOC, oversees the Americans with Disabilities Act requirement of reasonable accommodations for employees with disabilities, unless there would be undue hardship on the employer or others might be directly threatened. And they also oversee Title VII of the Civil Rights Act requirement that there be reasonable accommodation for religious objections, unless an undue burden would result for the employer. Finally, the Occupational Safety and Health Act requires employers to provide workplaces free from hazards that are likely to cause death or serious physical harm. These two agencies have not issued any specific guidance on COVID-19 vaccines, but that kind of guidance could actually shape whether these mandates are implemented on a wider scale. Additionally, an EUA authorization itself could confront the issue, as individuals taking an EUA vaccine must be given the option to refuse and informed of the consequences of that refusal. But the Act does not state that a refusal has to be honored without any resulting employment consequences. Now, along with those mandates, this next issue, vaccine exemptions, will also really shape how effective any potential vaccines and those mandates will be. So as previously discussed, states have differing laws requiring vaccines in certain contexts, but along with those varying state laws come varying state-specific exemptions. All states allow for medical exemptions, most states provide religious exemptions, and some states additionally provide for general, moral, or philosophical exemptions. State emergency laws that allow for that compulsory vaccination during public health emergencies also can come with certain exemptions. Now, since the Jacobson and Zooft cases that I talked about were issued in the early 20th century, courts have generally concluded that states are not constitutionally required to provide religious exemptions because vaccine mandates are neutral. They aren't singling out religion. However, we might see a change in that approach based on the makeup of the current Supreme Court with the addition of Justice Amy Coney Barrett. On November 25th, the court issued Roman Catholic Diocese of Brooklyn versus Cuomo, stopping enforcement of New York Governor Cuomo's COVID-19 attendee limitations on religious observance in areas heavily impacted by COVID-19. The court singled out that limitation on religious organizations and determined that it was not neutral. After heavily scrutinizing the limitation, the court prevented its enforcement. The newly made up court has not weighed in on any vaccine mandates or exemptions as of yet, but the court's approach in Cuomo could signal a movement towards heightened deference towards religious practice. The new court could potentially find that the First Amendment's free exercise clause requires the inclusion of religious exemptions, even during a public health emergency, or could turn to the Religious Freedom Restoration Act as a potential means to elevate that legal status of religious exemptions to vaccines. Issue number 8 is informed consent. And this issue is a really interesting one as we get deeper into that world of mandatory and compulsory vaccination. What does informed consent really look like if the vaccines are compulsory? How can we ensure that a patient has given informed consent if he or she has to get the vaccine anyway? The quote on the slide, "Every human being of adult years and sound mind has a right to determine what shall be done with his own body." This was originally written by a famous New York Court of Appeals judge and later Supreme Court Justice Benjamin Cardozo in 1914, and it supports the origins of the doctrine of informed consent. That idea of bodily autonomy is certainly going to play a role in distribution and wider administration of the COVID-19 vaccine. And also as an aside here, the 8th Amendment, the amendment protecting against cruel and unusual punishment, could also play in here, especially with respect to inmate populations or wards of the state. On the one hand, it could arguably be cruel and unusual punishment to force populations to take a vaccine that potentially later could result in harm. But it's also arguably cruel and unusual to deprive these populations of a known efficacious intervention against a highly contagious and potentially deadly communicable disease like COVID-19. And when that harm does result, as it certainly will with a vaccine distribution of this magnitude, we then look to liability protections for providers and entities. Under the federal Coronavirus Aid, Relief, and Economic Security, or CARES Act, Congress provided a Good Samaritan provision which protects from liability interstate volunteer healthcare workers that are responding to the COVID-19 public health emergency. This protection expressly overrides all state laws except those that provide an even greater protection from liability, but applies to volunteers only and does not cover criminal or willful conduct. Another federal law that actually provides more robust liability protections is the Public Readiness and Emergency Preparedness, or PrEP Act. The PrEP Act authorizes the HHS Secretary to provide immunity to certain individuals and entities against loss claims arising out of the manufacture, distribution, administration, use of a covered countermeasure in response to a public health emergency. It does not cover willful misconduct. Now, we are currently under a PrEP Act declaration, which would extend that liability protection to the vaccine for COVID-19. Now, one final point I'd like to make here before transitioning to the next slide. This is not an exhaustive list of liability protections, and there may be several additional separate protections at each state level as well. Now, continuing on our discussion of the PrEP Act, on December 3rd, HHS Secretary Alex Azar amended the PrEP Act declaration to include liability protections for certain pharmacists and pharmacy interns who administer the COVID-19 vaccine, as well as practitioners using telehealth. This is really important because normally on the healthcare worker side, only qualified persons will receive immunity. And that applies only to people who are typically authorized by state law to administer those countermeasures, to administer, in this case, a vaccine. That doesn't necessarily include pharmacists or telemedicine practitioners in all states. One other interesting point on the PrEP Act, which marries well with that issue of informed consent that we discussed earlier, there have been trial court decisions upholding PrEP Act liability protections in cases involving failures to obtain informed consent. But that said, remember, the PrEP Act does not protect or extend to willful misconduct. Now, when these liability protections that we've talked about come into play and harm results, there are still some options the injured can turn to for compensation. Doug will cover this in some detail, but there are a few programs that provide compensation for persons injured by vaccines. The National Vaccine Injury Compensation Program provides compensation for injuries caused by routinely administered vaccinations. And the Countermeasures Injury Compensation Program provides for reimbursement of reasonable medical expenses, loss of income, or survivor measures for individuals seriously injured or killed by PrEP Act countermeasures. That concludes our discussion on some of the top legal issues identified with respect to COVID-19 vaccine allocation, and I will go ahead and pass it over to Doug to discuss safety and effectiveness. Thank you all for having us.
Okay, thanks. Can everybody hear me okay? Gives me a thumbs up. All right, here. I will go ahead and start my talk, and I'm going to talk about how the federal infrastructure assures vaccine safety and effectiveness, and how that's modified for the coronavirus situation that we're in now. Okay, wrong way. Okay, first of all, I would like to disclose that I have served as a member of the Advisory Committee on Immunization Practices. I was 5 years as a liaison and 4 years as a voting member. I currently provide consultation services to the Advisory Committee when it comes to assessing vaccine safety and effectiveness and making recommendations. And I'm currently involved with that, with the coronavirus vaccines that are being considered at the moment. So I'm going to talk about the FDA process for approving vaccines. We'll talk about the federal infrastructure that's available for that is in place for assessing vaccine safety. We'll talk about how recommendations are made and where you can find them. And then the federal system for compensating those who are affected by a rare but serious vaccine-related adverse event. So here are the vaccines that are currently in human trials in the United States. The top two are the ones that are being considered by the FDA currently. They're both messenger RNA platforms, which these will be the first human vaccines approved in the United States using this platform. Pfizer, the vaccine by Pfizer is under consideration today by VRBPAC, and there's anticipated to be a decision by FDA over the weekend. Moderna will be considered by VRBPAC and the FDA next week. The Advisory Committee on Immunization Practices is already examining data as well in preparation for their recommendations, which will come shortly after the FDA. So here's this federal structure for vaccine oversight I want us to spend a little time discussing. At the top is the Department of Health and Human Services. Below that's the National Vaccine Program. And the National Vaccine Program is a national office to coordinate vaccine activities, including oversight of vaccine safety. It sits within the Department of Health and Human Services, has an office in the Humphrey Building in Washington, D.C. and they have a vaccine safety working group that they also have looking at vaccine safety. The three major Department of Health and Human Services organizations involved with vaccine safety are HRSA, the Food and Drug Administration, and the CDC, Centers for Disease Control and Prevention. The Food and Drug Administration is responsible for approving or licensing vaccines for use in the United States. They have a Vaccines and Related Biological Products Advisory Committee, from this point forward referred to as VRPAC, and they make recommendations to the FDA regarding vaccines. Now, the FDA, that is, the leadership can accept or not those recommendations, generally accept. The Health Resources and Services Administration administers the Vaccine Injury Compensation Program, and I'll get into a little bit more depth on that a little bit later in the talk. The CDC has staffs the Advisory Committee on Immunization Practices, and they then have working groups. This working group here that I've on this slide is not just substitute the words MMRV with COVID-19. And there's a currently coronavirus or COVID-19 work group that is looking at all the vaccines being considered. The two that I just mentioned right now are under consideration. And they will make recommendations to the Advisory Committee on Immunization Practices. And that committee will make recommendations to the Director of Centers for Disease Control. So we've talked about the FDA approval, and the normal process is that VRBAC will review effectiveness and safety data. They meet, I think on an every 3 or 4 month basis, and things go along at a normal pace. The process can be speeded up, however, and one is to just expedite it, meaning you meet more frequently and you do your work faster. There's another way to speed up things, which is to use an emergency use authorization, which I'll describe here in a minute. There's also an extended use authorization. I'm not going to get into that today because it has to do with kind of a compassionate use of certain biologics, and it's not a consideration for these vaccines. Now, if a vaccine is approved by a EUA, that is for the time that public health emergency is declared. After that, it has to be approved through the normal process. So here's what an EUA is. It's authorized through a certain act that authorized the FDA. The FDA commissioner may allow unapproved medical products or unapproved uses of approved medical products in an emergency to diagnose, treat, or prevent serious or life-threatening diseases or conditions caused by a chemical, biological, radiological, or nuclear threat agents when there are no adequate, approved, and available alternatives. So certainly these vaccines that are being considered do fit this definition and can be authorized under an EUA. Now, the EUA requirements, I want to just look at that second paragraph there. Based on the totality of scientific evidence available, including data from adequate and well-controlled trials, if available, it is reasonable to believe that the product may be effective to prevent, diagnose, or treat such serious or life-threatening disease or condition that can be caused by SARS coronavirus 2. All right, so if the weight of the evidence leads you to believe that these vaccines may be effective and there are no alternatives, then it meets the criteria for being authorized here. It's pretty lenient. And currently we don't have alternatives to these vaccines. Now, the FDA then set some criteria, which was the subject of this controversy previously mentioned, to try to reassure the public that they weren't going to approve under emergency use authorization unless certain conditions were met. And they're included in these bullets. And that the efficacy of the vaccines has to be 50% or more in terms of preventing some outcome, generally symptomatic COVID. At least half of the phase 3 studies need to be followed for safety and efficacy for at least 2 months. So that's a median of 2 months follow-up. And then safety data throughout clinical development, including well over 3,000 phase 3 recipients to evaluate reactogenicity, serious adverse events, and adverse events of special interest. All right, so, and then there has to be sufficient cases of severe COVID to assess the effectiveness of these vaccines. So the FDA is going to determine whether these vaccines that are being presented to them meet these criteria. And I'm pretty confident that they do, because we've seen the data. The FDA has published their assessment, so it's public knowledge. And it does appear, and the FDA has pretty much asserted that these 2 vaccines being considered meet these criteria that they set. So what happens after the FDA approves? Hold on. It looks like some of my talk is missing. Hang on. After FDA approval, the next slide comes up is the question. So, all right, I'll just do this off the cuff. So after the FDA approves this, the Advisory Committee on Immunization Practices assesses it. The Advisory Committee on Immunization Practices, the coronavirus work group, has been having regular meetings for months now. They're well prepared to make a determination. They do not have to agree with the FDA. They can disagree. I don't think it's likely in this situation that they'll do so, but they'll make a recommendation, and there's a special meeting scheduled for tomorrow and for Sunday for the ACIP to vote regarding recommendations for this first vaccine, which is the Pfizer one. There'll be meetings next week. Normally, the ACIP meets once every 4 months, and they've been meeting regularly in a kind of an emergency situation, meeting much more frequently by phone. So the ACIP will make their recommendation. I anticipate it'll be very close to the recommendation by the FDA. Then the vaccines will start being distributed even before the ACIP makes their recommendation, but it gives an added, I think, confidence to know that the ACIP has looked at the safety and the effectiveness of these vaccines, considered all kinds of other things, such as the morbidity, mortality to be prevented, and whether the implementation is practical and whether it makes sense financially. And all of those things are kind of moot points for these particular vaccines, but under normal circumstances, these things are given much more credence because it's not an emergency situation. So after then the ACIP approves, states are then actually kind of free to accept these recommendations or not. I heard about all these other committees being formed by these states. I am quite confident that these competent scientists in these other states will look at safety and effectiveness data and come to the same conclusion that the ACIP will come to. I'm not worried about that at all. And if it enhances confidence in those states, then that's fine. Now, once the vaccine is used, there is a surveillance system, and this is kind of where I'm going to miss my slides a little bit. There's a surveillance system set up to monitor for vaccine safety. It's there all the time. There's the base of the system is the vaccine adverse events reporting system, which is a passive system where people can call in, providers, anybody can call in if there's a suspected adverse reaction from a vaccine. The CDC monitors these reports on a regular basis. It's going to be on a daily basis regarding coronavirus vaccines. Normally, it's a little less frequent than that, weekly. But they're going to be looking for concerns from coronavirus vaccines. If there's a concern that kind of pops up in theirs, it does not prove causation. There's then another system that's pulled in, and that's the Vaccine Safety Data Link system. which is a series of health maintenance organizations around the country that can do real live analysis of vaccine safety. There's other enhanced safety systems in place for these vaccines, including the Department of Defense. They have very good records, and they monitor vaccine safety among the military quite thoroughly. The Veterans Administration is going to also have a system set up using their records and electronic records and looking for safety signals. The Indian Health Service is going to do the same. And the FDA is setting up some enhanced surveillance systems using electronic medical records and some major health systems around the country looking for any serious adverse reactions resulting from these vaccines. The system is actually, even in normal times, is quite robust. And a vaccine that causes any serious adverse events of any magnitude is caught fairly quickly. Now, it's going to be much faster with these coronavirus vaccines. I feel quite confident that the safety surveillance system will catch any safety signals fairly quickly. Now, if there is an injury or an adverse event, we do have what's called the Vaccine Injury Compensation Program. This was started in the mid-1990s because we had a number of vaccine producers going out of business because of liability claims and suits and being in court a lot. Now, this is a rather controversial, it's actually not that controversial of a program among the vaccine community. It basically saved our vaccine program because companies were beginning to drop out of vaccine production. If you're an anti-vaccine person, you see it as shielding vaccine companies from their liability. I don't see it that way at all. I see it's protecting them from unwarranted liability claims, keeping them out of court. And if someone does suffer a serious adverse event from a vaccine injury, that is very rare, but it can happen. There's a system to compensate them for it. It's a non-fault system. It's set up through a court, a vaccine court in Washington, D.C. These judges look at vaccine compensation claims all the time. They're very good at sorting out the science. And there's a list of adverse reactions that we know can occur. If your injury is on that list, you meet certain criteria, you will be compensated. If your injury is not on that list, you can still file a claim, and the staff at the injury program at HRSA I described previously will assess it. If it looks like it's a probable injury caused by a vaccine, they'll concede the case and you'll get compensated. If that doesn't happen, you go to court, and the judges look at your evidence, they look at all the evidence, and they will determine whether the evidence there is more likely than not, the chance that your vaccine injury, your claim was caused by a vaccine, is more likely than not you'll be compensated. So the system actually is very good. It's funded by a tax on vaccines that are sold. It has millions of dollars of excess money in it because even though the average award exceeds $1 million, the awards are so rare that the program has a bunch of excess funds in it. And the people who get involved with it like it. It's a fast system. It's about a 2-year from start to finish versus the civilian courts, which are average 3 to 4. And if your claim is not awarded, if you lose your claim through all the steps in the Vaccine Injury Compensation Program, you can then go to court. But most people don't because you just don't have a lot of evidence to support your case in those instances. So it's a very good program. It's a very successful program. And there's a similar program for countermeasures, which uses the same type of system. A countermeasure, which these vaccines would be considered, funded by federal money, that any injuries will be compensated using this similar type system. So to summarize it up, even in normal times in this country, we have a very transparent and a very robust system for assessing vaccine safety and effectiveness, for approving vaccines, for funding vaccines, and for monitoring for vaccine safety with time. Now, this system has been enhanced for this particular circumstance regarding coronavirus vaccines. It has been expedited, and it is true that in normal circumstances, we would like to see a longer period of time, particularly for vaccine safety. That makes these enhanced surveillance systems for adverse events even more important, but the system is there. It is going to operate, and I am confident it will detect any serious adverse reactions occurring, even at a low rate, fairly quickly. So I have a lot of confidence in the system. We'll see how it works. And, you know, my main final concluding line is the system really does work as long as it's not messed with and we don't get politics involved with it. And I think the FDA has seen that potential, and with those special considerations that they put in has helped to alleviate that. The Advisory Committee on Immunization Practices, I can tell you, is not receiving any outside interference. They will make an independent judgment. These are independent people, not CDC employees or government employees. And the surveillance system for safety will operate. So I would just like to reassure people that I'm pretty confident in it. So I'm going to stop there and go to the next slide, which is thoughts and questions. And I think this goes back to Leila for being the coordinator for this, I think.
Thank you, Doug. Thank you, Jen. Those were amazing presentations, so informative and helpful. And I know we have about 15 minutes now for questions. So I think the next slide, there we go, provides instructions. If you'd like to enter a question into the Q&A panel, you can select all panelists, type your question and hit send, and I will share the questions with our two great panelists today. While you are all thinking about questions, I have a couple to actually start us off today. And the first question goes to Jen. And with respect to the liability protections in the vaccine compensation programs, how might proving the injury work if an injury does not manifest itself immediately, but occurs, say, 5 years down the road? And I'll share this with Jen first, but Doug, please, we welcome your thoughts as well.
Thanks, Leila, for that great question. So first, in order to understand that PrEP Act, the CICP program that provides that compensation, it's important to recognize that program actually requires compelling scientific evidence to demonstrate that countermeasure, the vaccine here, directly caused that serious injury. And that compelling evidence can become harder and harder to produce further and further out from administration because you need to have that really tight link. So if the individual, though, were able to make this showing compelling, the CICP would still be able to provide compensation in this scenario. But the liability protections, those are going to be tied to the date of administration, the PrEP Act authorization, and the kind of product that's administered. If at the time of administration it was a covered countermeasure covered by that PrEP Act emergency declaration and administered by a qualified individual, then those liability protections would still apply.
Thanks, Jen. Doug, did you have anything you wanted to add before we move on to the next question?
Yeah, I do. I don't have anything to add to what Jennifer said. That brings us up to, well, what happens when the EUA is over, the public health emergency is over, and these vaccines continue to be used? Well, my sense is at that point, we'll kick into the vaccine injury compensation program. And with time, those vaccines will be scrutinized. And about every 5 years, the National Academy of Medicine reviews the literature on vaccine injuries and adverse events, and they'll update the table. If there's an adverse event or adverse reaction that's documented in the future to be caused by these vaccines, it will be on the table and people will be compensated. But it'll be under normal use, not under the emergency use authorization. So there is a mechanism for years down the road for a vaccine side effect to be uncovered, but it's going to have to be uncovered through a scientific method. And there's a number of ways that can happen, including individual researchers. The literature on vaccine safety is vast. So there will be lots of opportunity to uncover these kinds of events. This is always the bugaboo here. Well, how do we know 5 years down the road or 10 years down the road? Well, we know because we have surveillance systems in place, and if those things start happening, it will eventually be uncovered, in which case the vaccine injury program will begin to cover it.
Thank you both very much. We've had quite a slew of great questions coming in, so I'm going to try and get through as many as we can. I just do want to note, if there's a question that we don't get to, please know that you can always email us at the Network for Public Health Law following this webinar, and we will be happy to address any additional questions or concerns. Question I see coming in now, will hospitals be responsible for offering COVID vaccines to high-risk inpatients when the vaccine becomes available to those included in phase 1? Doug, I don't know if you want to start us off on that?
I'm not sure I understood the question. Is it because much of the vaccine distribution will be through hospitals, particularly early on, because the Pfizer product required such a cold storage, extreme cold storage. So the hospitals now, it's between the state and these distribution methods that they've set up to determine how they're going to hold hospitals responsible for sticking to these priorities and so forth. But my assumption is that if the hospitals are the ones distributing the vaccine or administering it, that the state will have worked out with them the priority list, and the hospital will be cooperating with the state to make sure that that happens according to plan. But maybe, Jennifer, I don't know, you may have more on that.
Sorry, I lost my mute button. No, I don't have anything to add to that, Doug.
Thank you both. We've had a few questions about mandating vaccines or mandatory vaccines. One I see has come up is there case law regarding mandating vaccines for government employees? Jen, if you want to take that for us, please.
So I will say I am aware of a specific statute that actually says the president can, under certain circumstances, go ahead and waive that option of refusal of the EUA vaccine for members of the armed forces. So that is a very interesting exception that's written into the law, but I'm not aware of any additional case law.
Yeah, I was going to say, on an everyday basis, the U.S. military, which by definition are employees of the U.S. government, are mandated to receive vaccines. So it's an ongoing thing with the military.
Thank you. We've also gotten quite a few questions for slides, and these slides and a playback of the webinar will be available on the Network for Public Health Law website. Another question that has come in for Doug, can you give your view on us being able to separate the temporally related post-vaccine adverse events from the causally related adverse events in the hyper-vigilant COVID-19 environment?
That is going to be a significant problem. And it's not going to be a significant problem from the scientific viewpoint, because we have scientific methods to determine whether something was a chance occurrence post-vaccine versus a causal occurrence. The problem is going to be out in cyberspace and social networking. And I am I just don't know how to handle that. I am anticipating a plethora of false information to be circulated. And as soon as somebody, and this is one of the things that come up in discussion regarding should the elderly be a priority group for the vaccine. And someone did mention it once, and I think it's a very valid point. Elderly people die at a regular rate by other things. And so you've now increased your chance of having a chance death in close proximity to a vaccine by vaccinating older people. Now, that did not carry the day in terms of saying we shouldn't vaccinate older people first, but it was a valid point. We are going to have deaths, other adverse events by chance, and the ability of the social media to sort that out is very dismal. And the trust in science and federal agencies right now, when we come forward and say, we've looked at this and could find no evidence of causation, and this kind of thing happens by chance at a certain rate, and we're finding, I'm pessimistic that certain segments of the population are going to believe that. So, really significant problem that I don't have an answer for.
Doug, that leads into another question. We've gotten some questions on distrust. One specifically, how will the government deal with vaccine distrust in some African American and Latinx communities?
I'm not sure I heard everything. It said, how can the federal government enhance trust?
How can the government deal with vaccine distrust in some African American and Latinx communities?
Well, I think with time, and we see how the vaccine performs, hopefully that will help. But I think there's a fair amount of outreach being done as well in these communities through thought leaders and opinion leaders and so forth to try to, enhance trust. But there's effort being given to it. I'm not sure I can specifically speak to specific programs and things, but it's known that this is an issue. We're going to have to do what we can. You can only do so much. I think the best thing that will happen with time is when the vaccines are shown to be safe and effective, people will have more trust in it. This social media thing, I'm just so pessimistic about this. I'm sorry, but we're going to have to find ways. Public health is going to have to find ways to counter false information, and right now we don't do very good at that.
Thanks, Doug. Jen, we've had quite a few questions on cost. The one question specifically: do health insurance companies cover partial or full paid COVID-19 vaccines?
That was a question for Jennifer, right?
Yes, I think Jen was having some trouble with her mute button.
Yeah, I keep losing the mute button. Sorry about that, guys. I do believe there was guidance issued by the federal government that vaccine doses that are purchased with U.S. taxpayer dollars are going to be covered. Fully no cost coverage. So yes, so that health insurance will kick in and cover the cost of those vaccines for those vaccines that were purchased by the federal government.
I think there's a caveat there, which is that may not pertain to the administration fee. And some states are actually taking action to cover that. And I think the state of Arizona might have done that. Leila probably knows that. But you say there's no administration fee allowed either, and the state is able to do that through a mandate for insurance companies, I think.
Yes, Doug, I do know that states are working on that and dropping administrative fees for the COVID-19 vaccine, and I think we'll see more to come related to that as well. Another question here. Who has CDC worked with to plan for the distribution of COVID-19 vaccines? And I believe we have about 2 minutes, so you could each maybe just give a couple quick thoughts on this. That would be great. Thank you.
I'll go first. I'm not sure what exactly is going on behind the scene. I just know that there's a lot of activity, and they're coordinating mainly with state governments. CDC is a very federalist-oriented agency. They work through state governments, and they provide guidance and recommendations, and then the state governments, depending on the circumstances, are free or not so free to follow CDC recommendations. So I think CDC right now is actively involved working with states and making sure they're working with tribal governments. In fact, the CDC may be working directly with tribal governments. I'm not sure. But there's just a lot of activity going on right now regarding this. I don't have the details. I'm sorry.
I would just add in there that National Academy of Medicine framework that I showed on one of my earlier slides. So that was a framework developed by the National Academy to provide some allocation type guidance to the CDC. So they are, very interested in these kinds of health equity concerns, providing the allocation in an equitable manner.
Well, our time is up, and I want to thank again Jen and Doug, Jen Piatt and Doug Himmelsautkult for joining us today. If you're interested in the slides or the playback, please go to the networkforphl.org. Our webinars are posted there, and we have some great additional information related to COVID-19 as well. Thank you all for attending this webinar, and I hope you all have a great day. Thank you again.